Good morning. Sorry I'm a little late. I turned right instead of left as per my instinct, so I hope I'm not holding y'all up too much. What I thought I'd do today is to talk about the use of graft materials in lower urinary tract reconstruction, and I'd like to focus more on vaginal reconstruction. We'll talk a little bit about abdominal surgery, but I think most of the controversy in this area lies within transvaginal utilization of graft materials. And before I start, I think it's important for me to at least name some disclosures. I'm a consultant for Stellus and Pfizer, and I also do some investigations for Solace, because you're going to hear some brand names and you're going to hear a number of different products, just to let you know that I have no commercial affiliation with any of these products or any of these companies, and so there should not be any bias within the corpus of this lecture. But I'm going to do something a little bit unusual, because many of you may have clinical duties, and so what I'd like to do is initially start off with where I'm going to end, or my conclusion. And I think that there is an evidence today, and I hope to impress upon you today, that I think when we talk about inserting a biologic graft material in the vagina for transvaginal surgery, it probably undergoes a process of remodeling. And as I'll show you, that may not be very good, because if you remodel into deficient host tissue, that may lead to some intermediate failures, and I think our clinical data seems to suggest that. I'd also like to present to you that I think the synthetic grafts actually undergo a different process. Because of the permanent nature of the material, they don't necessarily remodel into host, but what they do is they incorporate into host. And that can be a good thing, but then we have some of the nuances, such as delayed healing and other complications from a permanent material that may persist because it incorporates and doesn't necessarily remodel. That could potentially be a bad thing. There's evidence to suggest that clearly if you're going to do abdominal sacral colpopexy, synthetic grafts are superior, and that synthetic reinforcement of the anterior compartment may improve anatomic outcomes, but in the long end, is that really what we want to do? And that's the important question, because is there a functional loss, or are there other implications associated with this improved anatomic outcome? And I think that's the million-dollar question that many of us in this room are struggling with. And as far as the use of posterior grafts, I think the role for the posterior grafts are largely unknown, and I think until more data is needed, many of us are taking a more cautious approach before applying grafts in the posterior compartment. So how did I get to these conclusions? Well, I think we ought to start near the beginning. And as a urologist, the first introduction of graft materials in our transvaginal surgery occurred when we started using these materials to substitute for autologous slings. Actually, porcine dermis in the United Kingdom was the first graft substitute that was used, followed by our colleagues in California, Don Ostergaard, who used cardiac fascia lata, and that seemed to be the boom, at least in our area in urology, but using these materials for sling surgery. And obviously it had multiple advantages, the particular advantage being that it was shorter, it was simpler, patients recovered faster, and then there was an absence of local complications as well. And as you can see, does this point to it? Yeah, as you can see here, this is actually one of my patients that was done, that I did an autologous sling on, and you can see the hematoma that she developed from the fascial harvest. So clearly there were some local complications that we avoided, and so that made us much more comfortable utilizing these graft materials. If you couple the comfort that we developed with the concept of failures of the surgical procedures, and I know many of the residents and I talked about this yesterday, that many of these women have multiple risk factors to fail. They tend to be elderly. There's many connective tissue deficiencies. There's possibly some even neural deficiencies in these women that are going to set these patients up to have some sort of deficient tissue quality. And it's been estimated as many 30% of these women will need a second operation for prolapse. So clearly there's some desire, if you will, to try to overcome that. There's certainly a lot of evidence to suggest that many women undergoing prolapse and incontinence surgery have deficient tissue qualities, whether it's collagen, whether it's the elastase mechanism, or actually even decreased numbers of fibroblast. And in the United States, as I said yesterday, couple that with obesity and a high incidence of smoking, our women in some instances are already set up for failures, and so we were trying to figure out a way that we can reduce the failures but still maintain function. So when we're talking about adding an implant for this purpose, many of us would agree that the ideal implant should be readily available and affordable. It should be biocompatible and chemically inert. It should be non-carcinogenic. It should be strong, and in fact, it should probably be stronger and more durable than even autologous tissue, and it should have no detrimental effect on pelvic function. And then lastly, and most importantly, it should have minimal risk of infection and/or rejection. So I think all of us in this room would agree that if we think about the ideal implant, despite how good we think we've become and how good we think we're getting, we're probably not there yet with the ideal implant, particularly for transvaginal implantation. It's important to understand when we put a graft in the vagina, no matter what it is, that there's no graft material that's histologically inert. It's a foreign body, regardless of what it is, and it elicits a foreign body response, regardless of what it is. Most of these responses tend to form biofilms, and that can be important because biofilms in some ways can be good, but in some ways they can be bad. If the biofilm blocks the influx of protein and blocks the influx of fibrinogen and those substances that may actually defend against infection and a bad host response, that would be bad. The proteins that influx into the graft tend to undergo a conformational change. They tend to bind antibodies. Macrophages tend to infiltrate the graft and sometimes fight off any degree of inflammation, and those would be positive responses. So a biofilm that would not inhibit that process would be a positive response. For urologists, most of us are familiar with biofilms when we explant a prosthesis or an artificial urinary sphincter. You can actually tend to see the biofilm. Unfortunately, with the nature of these materials, you can't see the biofilm, but clear histologic studies suggest that they do exist. What I want to impress upon you today is, in my understanding of this, I think that there's a variance in the host response. When we looked at the biologic materials and we did some early work, we actually followed our orthopedic colleagues that were putting ligaments and redoing ligamentous reconstruction, and they felt an incorporation or transformation into the host tissue was important for that graft to maintain its long-term success. I tend to call that, if you will, bioacceptance, but then an ultimate transformation where it tends to replicate the host. That could be a bad thing, however, if you're replicating into bad tissue, and I think that's one of the concerns that we have about long-term use of biologics. The other would be remodeling, and that's infiltration of the host tissue into the graft, and essentially, if you will, transforming it, but still remaining and having the substrate of the actual graft material. In other words, serving as a lattice or a platform for host tissue incorporation, but not necessarily a complete remodeling process. Again, I think that can be good because it may transform, if you will, some degree of function, but still maintain its durability. But then again, if you're having a functional problem after you implanted it, that could be bad because of its permanence. And I think that's where we're struggling with today. But let's talk a little bit about this, because in the orthopedic literature, in the urologic literature, in the gynecologic literature, there's clear evidence to suggest that there is a tissue ingrowth process that occurs when you put these graft materials in. As you see here, is collagen fibrils, and the idea being is what you'd like to have is an orderly arrangement of the material, whether it's permanent or permanent or biologic, to promote an ingrowth of this tissue that I talked about, proteins, fibroblasts, blood vessels, into the graft substrate. And in fact, if you look at some studies, particularly in the orthopedic literature, they actually suggest that the fibroblast, it's an outside-in process. So they tend to infiltrate the periphery of the graft, as you see here. So notice where the P is, which you could hardly see. There's a lot of fibroblasts, as you see here. And then toward the center of the graft, there's less. So there's less fibroblasts and there's less blood vessels. And the idea being is this infiltration process needs to occur across the entire graft surface, or if it doesn't occur in a certain amount of time, the graft will lose its strength, degrade, and break down. And that's the idea of host tissue ingrowth, and then eventually remodeling, if you will, of a biologic tissue. So it appears for biologic materials particularly, if the graft is going to survive long term, this tissue must incorporate and then, quote, transform into the host. And that's what we call remodeling. And so it may assume the function of the host, and in some degrees may assume the antigenicity and even the function of the host. And that's what is thought to be desirable of biologic materials. So when we talk about these materials and we look at the classification of the grafts that are used in transvaginal surgery, one can see that we largely break them up into biologic as seen here and synthetic materials as seen here. Most now biologic use is pretty much restricted now almost to the xenografts, which would be porcine dermis, but there still is some cadaveric fascia and dermal applications. But for the most part, I would say the most commonly used biologic material now are the xenografts. If we look at the synthetic meshes, absorbable meshes were used transiently for a small period of time, but there's been a migration to these non-absorbable permanent meshes. And when we look at the classification of these meshes, the type 1 macroporous monofilament meshes seem to be the most desirable to implant, and I'll go over that for you and why that is. But if you look at this slide, and quite honestly, I haven't updated it probably in about a year to 6 months. If you look at this, there's probably more products that are on the market that are available to us today. So again, there's some variability in the implants that you're using. And in fact, if I'm using cadaveric fascia, it might be different than Jeff's cadaveric fascia based on the way that it's processed and based on the way that it's distributed. So understand, even within all of these materials themselves, there's a potential wide degree of variability on the performance of the graft that you're going to be implanting. And why is that? Well, the reason for that is the only guidelines, at least in the United States, that exist is to direct the harvesting and transplantation of tissue. That's it. So in other words, when you have harvested that tissue, there's no guidelines for how it's processed and how it's packaged and how it's stored. So it can be freeze-dried, it can be irradiated, it can be solvent dehydrated. There are a number of different ways that these are processed. And I'm sure that there's going to be some inherent alteration of graft function based on this process. And that hasn't been very well elucidated, unfortunately, although there are some small laboratory studies to suggest that it does indeed occur. So what about antigenicity? And many people ask me, well, what is going to happen? Is there a host, a tissue transfer of antigens? And there's some evidence to suggest that there may be some transfer, but it doesn't appear to be biologically, at this time anyway, biologically important. But if we look in the orthopedic literature, again, the risk of transmission of HIV from a soft tissue allograft is about 1 in 8 million, so very, very rare. But there is evidence, even in the gynecologic literature, so very close to what we do, that the processed tissue does retain the donor antigens. However, after a period of time and it's harvested, it's replaced by the host antigen. And again, that leads to that process of remodeling that we've been talking about. There's also evidence in two different labs, 2 different studies, looking at the actual products that we're implanting in the patients, and they've took them off the shelf and they processed them, and there were fragments of both DNA and fragments of RNA from the host that was still isolated from these tissues. But there was no potential for amplification based on their follow-up study, so we don't know the significance of this, but there clearly are some concerns, and it should be at least mentioned to the patients. When we look at the xenografts, well, there's potential advantages because that is a very, very standardized process. It's standardized by how it's prepared, it's standardized by how it's packaged. So when you're looking at that particular product, most of the time you're getting a very uniform product if you stay, for instance, within the company. Now, some brands do cross-link them, some don't, and that's an area of controversy. But for the most part, it's more consistent by the way that it's harvested and by the way that it's preserved. And so these tissues seem to be the more commonly implanted biologic materials now, whether it's availability or whether it's performance. Unfortunately, we don't have enough data to know. 2 comments. One is that there is some evidence to suggest that fenestrated graft materials seem to be more desirable than a thick, contiguous sheath, if you will, of porcine dermis. And that seems to make sense to me if I'm thinking about wanting this to incorporate. The issue of cross-linking is something to make sure that the graft remains more stable. So it's some process. For all of us who've injected collagen, we're familiar with that. Cross-linking can stabilize the implant, but then some have concerns that it may actually lead to degradation because of the fact that there's no incorporation, it resists incorporation. Unfortunately, there's not been a head-to-head study regarding that. So right now, I tend to ask more for fenestrated porcine dermis if I ever would use it. So the question is, what happens when a graft is put in? What happens to these devices when we put graft materials in? Well, there are several potential mechanisms for failure, and all of these were described early on. The most common was that the graft would break or they would rupture. So when the reps first came to our office, they were telling us to pull on it and tug it and see how tough this is because it'll never break, and that was our first concern. Our biggest concern was that the tissue would actually undergo an immunologic rejection, much like a transplant patient would undergo, and many of us didn't really even appreciate the concept of tissue degeneration. And so that seems to be the biggest problem that we face. So when we look at these biomaterials and we undergo the potential mechanisms of action, again, you can see that the material can break down and dissolve over time. The most desirable of a biologic graft was that it can incorporate and remodel and hopefully transform, if you will. And then lastly, one of the other problems is that it can encapsulate. As I mentioned, you can get an unfriendly biofilm that develops around the graft, and it tends to wall itself off. And that seems to happen most commonly with any type of processed porcine dermis. And the reason why I think that is because it reacts to the processing of the dermis if it's coated with something, and then it's too thick, and so therefore there's no incorporation, and it tends to wall itself off. In the graft materials like this, transvaginally, encapsulation is not a good thing. Many urologists challenge me on this, and they say, I love it when my artificial sphincters encapsulate. I love it when my prosthesis encapsulates. That's not a good thing in the vagina. That leads to local complications that we could get into and discuss even offline. So when we looked at the issue of tissue failure, much of the early emphasis was placed here, and in fact, we found that probably doesn't really happen. And in fact, if you look at the testing, the biomechanical testing that's done in the companies, and they hand you all these monographs, it doesn't replicate the cyclic hysteresis in the pelvis. And so something that we published in a biomechanical journal is we actually put it on a cyclic hysteresis, which is basically an inconsistent, variable force of pull on the mesh over a period of time, as opposed to one long pull. And we found actually that very few of them actually failed under those conditions. However, it's almost impossible to replicate, and nobody knows what the cyclic dynamic force of the female pelvis is. But there's clearly a difference in the way these products respond based on the mechanism of pull. And so there's really not a lot of data to suggest that they actually break. So if you fix them in the right spot, I don't think this graft is going to rupture early, and that's really not much of a problem. We also don't see that the immunologic rejection that we're familiar with transplant tissue doesn't seem to happen either. Most of them can get infected. They can cause local problems such as a draining sinus, but it's really not necessarily an immunologic florid or fulminant rejection. So the big problem is degeneration. And there's clear evidence of this in histologic studies, as well as now in some clinical studies that we'll touch on later. But it does appear that if you look at these grafts over time, they are prone to degeneration. And in my opinion, as I mentioned earlier, the mechanism appears to be the remodeling process doesn't occur rapidly enough before the graft material will actually break down or degrade. And there are a number of authors that have seen this. All of us know the famous paper that Fitzgerald and Brubaker wrote about on colpopexies, where they went back and the tissue was absent. Shlomo Raz followed up with a publication with transvaginal surgery, and we also did the same when we looked at cadaveric dermis. So this implicated both cadaveric fascia lata and cadaveric dermis, all with a propensity to develop an intermediate failure. And actually, I think now there's evidence to suggest that the clinical data is following these early findings. And this is what a suggestion of this is. This shows Mary Pat's paper looking at the autolysis, is what they called it, in about 20% of their freeze-dried gamma-radiated grafts. And Dr. Raz's group also found that the freeze-dried gamma-radiated grafts also seem to have this process occur as well. So if you're going to be using a graft material, some are considering using solvent dehydrated because there's less, if you will, basic data to suggest that that's a process that can occur. Well, so the question is, that's great. In theory, we see it, but does it really happen clinically to our patients when you really want to put the rubber to the road? And the answer to that is, the answer appears to be yes. Fred Govier in Seattle, who many of you may know, published a very nice paper where they looked at their initial experience utilizing cadaveric fascia lata for the implantation of slings. And their initial reports was wonderful. They told everybody, you should do this, it's great, the patients do well. But then when they actually went back and followed them, they found a higher rate of failure, or intermediate range failure, when compared to their autologous fascia groups. And actually, we did the same thing. We went back and looked at our cadaveric dermis experience, albeit in a smaller number of patients, and we found that our failure rate of about 6% at 6 months seemed to magically transform to 32% at 14 months. And that didn't seem conceptual to me. I would have figured about 6 months. I would have figured at 14 months it would have been scarred in position and everything would be fine. But that's not what happened. And so there appears to be some intermediate risk of failure in these grafts. So we're making a case for synthetics, right? I mean, you might do a great surgery that may fail over a period of time. And so many would say then you need to consider a synthetic material because it's readily available, it's inexpensive, it's strong, it's permanent, no potential for disease transmission, and it doesn't emulate, nor necessarily, it may not emulate, if you will, the host tissue, meaning it may not remodel into the bad host tissue. And in my opinion, lastly, one potential strength is it doesn't remodel, it incorporates if done appropriately. So I talked about the mesh characteristics before, and we looked at the AMIT characteristics, and it's from hernia surgery, so it's not a transvaginal classification. But what I think it is powerful for it makes us think about the different types of mesh. At first, when we were putting mesh in, we were putting these thick sheets of even Gore-Tex in the vagina to try to help hold our repairs into position, and we discovered over a period of time that that was not good. What we discovered is the macroporous and monofilament meshes seem to be most desirable because, number one, they're flexible, so they're easier to implant, put them where we want, and then number two, they have this porosity, if you will, that allows this incorporation of the host or of the graft, which is quite important. So as you can see here, this old slide that looks at some of the different types of graft materials, again, most would say polypropylene. This type 1 mesh is the most desirable. And so what I want to do is just kind of, for the purposes of discussion, to show you the differences in these mesh materials. And so you can see the Merceline mesh, as you can see here, and you would think that that is a very desirable mesh due to the large pore, and when you compare it to this Marlex, which is usually now polypropylene mesh material. And so when you look at it, you can say the pore size are quite favorable in these 3 mesh materials. However, if you look further at the filaments, one can see this multi-filament nature here. And so these small interstices right here, and of course the multiple small interstices right here, can be an area of, quote, bacterial adherence. And so it's not macroporous in that area, and so therefore there's going to be a lack of infiltration of that area, so then there may be a potential problem with host defense of any foreign body reaction that might occur from this. Whereas opposed to this monofilament nature, one can see it's loosely woven with large pores, and so there should be a more rapid, even microscopic influx of these tissues. And so that appears to be the big difference, the pore sizes, the monofilament nature, and then if you see here, the large spaces between the fibers to allow a uniform infiltration of the entire graft, and that's what makes these materials more desirable. So this is what most people are using today, and this is a polypropylene mesh construct, and this is actually a picture from a sling, but many of the Prolapse kits are now adopting a mesh similar to this as well. So we've talked a lot about theory, and most of it, unfortunately, today still is theory. But is there any evidence at all that there's a difference? And I think there is. I think there, although it's not abundant, but I think there is some evidence to suggest that there is a different response to these materials that are put in, and it occurs both in an animal and in a very, very crude human model, if you will. But this study that was done looked at putting 6 different types of graft materials in an animal model, and it was a time-controlled explant to basically perform a systematic immunohistochemical analysis of the graft materials. And without belaboring the point, they did find that the degree of inflammation varied, and it was an interesting finding that the mesh seemed to have the lowest amount of inflammatory response, but the degree of scarring was highest in the mesh. And that seemed to, in some ways, it didn't make sense to me initially, but then when you dive into it, there may be less of an inflammatory response elicited in the absence of a biologic material, and more of a foreign body / fibrotic response in the presence of a synthetic material. So in some ways, when you started reading it, it did make some degree of sense, but what this study suggested in a time-controlled animal model that there is a difference in response. So we wanted to try to look at this a little bit differently, and there's no way that you can do a time-controlled explant in a human model. It's just not going to happen. But what we decided is we paired with Vanderbilt, and what we decided to do was to take everything that we've ever explanted over about an 18-month period, and we created, if you will, a data set or a data bank where we found the time of the original surgery, what original surgery was done, what implant was used, and then we went through some other comorbidities, and then we figured out the time that it was explanted from the time that it was implanted, and we built a table based on that. And so that was the best that we could do as far as trying to match it from the time that the graft was in. And we did with Vanderbilt, and we did it at LSU. All the studies were processed. Everything was sent to LSU. So we had one pathologist that did it after we did a systemic, if you will, macroscopic analysis at the time of surgery that all the surgeons agreed upon. And what we found is that with all these different graft materials, there's clearly a varying degree of several things. Number one, graft degradation, meaning when we opened it up at a similar time frame, some of the grafts were completely gone, some of the grafts looked like they were never even touched. The appearance of the graft obviously then was different. And then we saw that there was a difference in the degree of host tissue infiltration, both macroscopically and microscopically. And there was a difference in the fibroblast count and the neovascularity. And these were all done, as I mentioned, from the human explants. And this is just a picture, if you will. This is a similar time explant. So they went in, and within 30 days, these were taken out around the same time. And so this was about 12 months after the explant. So this is a piece of porcine dermis and a piece of polypropylene mesh that was explanted at 12 months. And so when you look at it, you can clearly see the marked difference in host tissue infiltration. So from the mesh relative to this piece of porcine dermis, which actually encapsulated. And in some ways, this actually made me more comfortable with mesh because it was very, very little inflammatory response. It was incorporated. So if it's in the right position, that actually may be a desirable thing because it's basically serving as a lattice or a platform of this material. And so then when we looked at it microscopically, it was amazing that many of the principles that we just talked about actually existed microscopically. And so you can see the control autologous fascia graft. Look at the uniform distribution of the fibroblasts in the blood vessels. This is a porcine dermis graft that encapsulated itself, so you can see nothing infiltrating this graft material. This is the cadaveric fascia lata that you can see. Again, we talked about peripheral implantation, less in the center of the material. And then lastly, this is a piece of mesh, more uniform and a higher foreign body response and a higher degree of fibrosis. So for me, the clinical implications were there. I think that this is leading some credence to this data that these materials do seem to act differently. And so what we concluded that the host tissue infiltration was highest in mesh. So it wasn't necessarily rejecting. In fact, if anything, it did encapsulate and it became incorporated quicker per volume of time. And so we concluded that the mesh can act as a scaffold to promote this incorporation process. We also concluded that the degradation in the cadaveric tissue may actually have legs to it, meaning we actually think we're seeing it, the process in the human. And then lastly, we found that the porcine dermis grafts, particularly the non-fenestrated ones, seem to be the ones that were most prone to encapsulation, which, as you can see why, I don't think it's such a good thing, that material is just sitting there without any degree of host response. So let's look at some of the clinical data. We've talked a lot about still theory, and we talked a lot about looking at this on a microscopic level, but let's look at some of the clinical data. Before I do that, I think it's important for everyone in the room to understand it's quite difficult to compare this clinical data. It's hard to compare apples to oranges, and so they don't necessarily equal each other. And the reason why I say that is because the procedures differ. Mesh procedures tend, for the most part, to be a multi-compartmental repair. We talked to the residents about that yesterday. When many people are using mesh, for the most part, they tend to be addressing more than one compartment. So if you compare that to a colporrhaphy procedure that doesn't address the apex or doesn't address the middle compartment, by itself, that's not fair. You can't do that, okay? And so I think you've got to be very, very, very careful to discriminate and really read the technique of the two procedures to make sure you're comparing apples to apples. And then lastly, the biggest problem that we have is many people define success differently, and so that's hard to some degree to incorporate. But if we're going to look at this, what I decided to do, for the interest of time, was to break this down, looking at biologic materials both in slings and prolapse, and then synthetic materials in slings and prolapse, and then we'll touch a little bit on randomized trials. As I mentioned to you earlier, if we look at the allograft sling, and this is Don Ostergaard's pilot study, where they had a very high success rate using cadaveric fascia lata, and they concluded there was no complications related to the fascia lata. A number of authors followed up with very favorable reports looking at utilizing these materials as graft substrates. But I've already showed you many of these favorable reports were followed up with actually declining data. And as you can see here at the bottom of this slide, notice some of the numbers here, 69, 79, 65%. So over time, there appeared to be this pattern of intermediate failures of some of these materials that actually happened with multiple authors and with multiple biologic grafts. And so there seems to be, I think, some evidence to suggest that there may be failures of these slings over time. And so that's what I tend to warn my patients if I ever do a biologic sling on a patient. Xenografts, the porcine dermis literature, quite honestly, is pretty good. There's an 85% cure rate at 12 months, 76% cure rate in some studies at about 12 months. But the problem here, and where it's hard for us to draw conclusions, is the porcine dermis sling started coming right around the time the mid-urethral sling came in. And so we really don't have a lot of good long-term or even intermediate follow-up of many of these earlier reports from the porcine dermis slings. So we don't really know what happens to these slings over an intermediate time frame because of the explosion of the synthetic slings. So when we look at the synthetic slings, pretty much all of us in this room are very aware of several guidelines, now the recently published AUA guidelines, that suggest that the potential for cure of these slings at 4 years is about 80%. And that's been replicated in many, many different studies by many, many different authors. And so when you look at it, you can see cure rates, of the, some of these went over, so I apologize, but you can see cure rates well within the 90th percentile in many of these patients. And so the cure rates of these slings are certainly higher, and it appears to be more durable based on looking at some of this non-controlled data utilizing the synthetic slings. But the problem is that there may be some trade-off. There's erosions or vaginal exposure of the slings that can occur now in most would say about 10% of the patients. So there are some complications that are unique to the mesh, but fortunately with the mid-urethral sling, it doesn't appear to be that bad, particularly if you compare them with some of the transvaginal mesh kits. Let's talk about prolapse repair. So again, if we look at the biologic materials, and I show you this graph to suggest, once again, even if, albeit a small number of patients in a fairly early time frame, initially some of the early data, which was encouraging, was quite good. But then if you look at some of the authors, actually even in an early to intermediate time frame, utilizing cadaveric dermis and porcine dermis, that there were some intermediate failures, and so the failure rates were higher than many of the studies that you'll see quoted utilizing synthetic mesh materials. So if you look, there are a few randomized trials that address this issue. And I'm not going to go through all of them necessarily in great detail, but what I will tell you is that the results are mixed. There are some trials that suggest that there really isn't a substantial difference if you randomize a corpora necessarily to a graft, and some trials that suggest that there's superiority. And the best way that I can frame it for you is to make sure that the authors are doing the same procedures. And because I think it's quite important, and then also to make sure the status of the apex, as we talked about before. But this appears to be the trend, and this appears to be what most people are tending to find. If you look at synthetic mesh, and some of these use kits, some of these use patches, like I showed the residents yesterday, but if you look at this, if you look at the column all the way to the left, one can see that the successful outcome in these products, the anatomic result does appear to be better. This 90 to 85 to 90%, 95% success rate appears to be the number that most people are getting. And so there's evidence to suggest that perhaps maybe this graft incorporation of a synthetic material may be improving the anatomic results. And if you look at this mesh versus no mesh, where these studies were actually randomized, you can see that if you look at the types of mesh, again, whether it's self-cut or a kit, and the patients are randomized and followed, you can see that there seems to be an advantage of the anatomic result of the mesh. But as I told the residents yesterday, for me the million-dollar question is that 72 and 67% so bad if I'm not introducing any risk of any sort of functional implications from the mesh that I may not know? And for me, again, as I said, that's the million-dollar question. Because if you look at the complication rates, one can see there's a trend that the mesh may introduce a bit more complications, and that there may be some more unique complications to utilizing these meshes, particularly in the anterior compartment. So if we think about the outcomes, the mesh repairs may be yielding a better anatomic result at 1 to 3 years, with about a 10% extrusion, which I mean vaginal erosion rate. And as far as dyspareunia is concerned, some say there's no difference. I tell my patients I don't know. And the reason being is, first of all, I don't think we do a good job measuring it. And second of all, I don't think the way that it's currently being reported, we're measuring it well, and I don't know. But it seems counterintuitive to me to tell a patient that there's no risk or really no difference if I'm going to introduce some sort of foreign substance like this, that there's no potential risk for dyspareunia. The one study that's been widely quoted that many of the mesh advocates are utilizing suggest that there's no difference because the patients undergoing surgery had a high risk of dyspareunia before the surgery was even done. And so I think that that's a little bit, in my opinion, potential misleading. So the best way to summarize it is we just don't know. But this can be the problem, and these are actually several of my patients, and I don't know now, we call it mesh in and mesh out. That's my OR day now. Some mesh comes in, some mesh comes out, and that's what my fellow basically calls my OR day. And so this is obviously a urethral TVT procedure that you can see here. Unfortunately, this TVT is basically right in the urethra at the bladder neck, and there's a stone, as you can see, attached to it, protruding into the bladder. And this patient required a laser removal of the stone, and then we just did a urethral reconstruction and took the mesh out. And so these complications are occurring in my opinion, with varying degree of frequency, but clearly patients at least need to be warned about the potential for mesh complications. In the United States, they need to be warned for several reasons. One is that the Food and Drug Administration of the United States released a public health notification, meaning the use of graft materials in vaginal surgery and the use of these products in transvaginal surgery has been associated with complications that they even say that you need to tell your patients you may not be able to reverse, even after multiple surgeries. So it's a pretty discreet, pretty descriptive warning, and I think one that if you're using mesh, you at least need to be having some sort of dialogue with your patient so they know that there may be some potential for a mesh issue. So when the Food and Drug Administration released this public health warning, I put some of the interesting caveats in yellow, and I apologize, it's a busy slide, but at least in the States, this is very, very important for the clinicians because the FDA is recommending that you obtain specialized training for each mesh technique that you do, that you inform the patients that implantation of mesh is permanent and that some complications associated with the implanted mesh may require additional surgery that may or may not correct the problem, that you inform patients about the potential for serious complications and their implications on quality of life, including pain with intercourse, scarring, and narrowing of the vaginal wall. And then lastly, that you provide patients with a written copy of the labeling kit from the manufacturer, if possible. So those are pretty significant comments by the FDA. I don't know of any other area that I practice in urology that these recommendations are being made to me when I consent my patients. And so the FDA took this quite seriously. If you Google, in the United States, if you Google transvaginal mesh, about the first 10 to 15 sites that you get are lawyers for a class action lawsuit. So, what are some of the things? I want to close by just telling you what I tell my patients. And basically, when I tell my patients, vaginal exposure of mesh is going to happen about 10 to 13% of the time. Meaning, no matter how good the surgery is done, you're going to come back to me, and there's going to be some mesh that's exposed through the vagina that we're going to have to redo and refix. As far as dyspareunia is concerned, I tell the patient that I don't know. But there's some studies that suggest about a 20% potential incidence of dyspareunia when using an anterior mesh, and that's what I'm quoting my patients. I tell them in the posterior compartment we have no idea. There's one study that suggests that up to half the women had it. I don't think that it's quite that high, but I do think that the incidence of that is probably much higher in the posterior compartment, particularly if it's attached to the perineal body. And so I think those are some important things that you can discuss with your patients, but you clearly need to talk to them about the extrusion of the vaginal exposure, the rare potential that it gets into the urinary tract, which we call erosion, which seems to be quite rare. Those issues absolutely need to be definitely discussed with the patient, and they need to understand it. So, how does this work, and how does this fit with an abdominal approach, the abdominal sacral colpopexy? Well, as I told the residents yesterday, many authors, despite how they do it, report an over 90% success rate using this procedure, and now with robotic and laparoscopic technology, this clears to be one of the standards now for supporting the apex. The overall incidence of mesh erosion in a meta-analysis done by Ingrid Nygaard, looking at all the reports of colpopexies, suggested that the mesh erosion, meaning exposure through the vagina, was 3%. Much lower than if you did it transvaginally. And in fact, if you use polypropylene mesh, that number goes down to about 1-point-something%. So 3% is including Gore-Tex and is including Teflon, and obviously we don't do that as much anymore. And I'll be honest, I can't even remember the last time I had an erosion of a polypropylene mesh through the vagina like this that I put in from an abdominal sacrocolpopexy. And as I mentioned earlier, there is some level 1 evidence to suggest that the synthetic material is superior to biologic materials in the abdominal sacrocolpopexy. So if you're going to do a colpopexy, you should be considering a synthetic mesh. So the way that I summarize all this clinically, as I apply it in my clinical practice today, I tell my patients that when I think about biologic materials, number 1, there's a variability in my graft to your graft, and number 2, the intermediate rate of failure is probably higher utilizing biologic materials. As far as synthetic meshes is concerned, I tell my patients that the type 1 macroporous monofilament mesh is most desirable. For the abdominal sacrocolpopexy, there is level 1 evidence to suggest that should be the standard. For the anterior compartment of the vagina, transvaginal use of mesh appears to improve the anatomic outcomes at 2 years, but we still don't fully have a grasp on the functional implications of that. In the posterior compartment, there's really no evidence at all right now to suggest that there's any advantage to putting mesh in, and so I tend to back away from using mesh in these patients. And so when we go back to the anterior compartment, as I'm having this conversation with our patient, we have to balance the pros and cons. And at the end of the day, most of the time, my patient makes the choice, and I basically have them tell me what to do. So I'm going to close by what I consider are some of the contemporary principles for the practicing clinician. As we talked about before, if we look at the abdominal sacrocolpopexy, there is level 1 evidence that I think verifies some of the histologic data that I showed you, that that's a synthetic graft is better than a biologic graft. The macroporous monofilament synthetic grafts are the one that you want to implant and the ones that you want to use. The non-cross-linked biologic grafts also that are fenestrated seem to have the highest degree of host tissue incorporation, but unfortunately, those biologics still may remodel and they could degrade. So I think it's important to understand that there's level 1 and level 2 data to support the use of mesh materials in abdominal sacrocolpopexy being level 1, and level 2 being the use in the anterior compartment transvaginally, but there's still some functional implications that we don't know. And then lastly, there's no conclusive data at this point to recommend the use of grafts, particularly synthetics, in the posterior compartment. So thank you for your time. I appreciate it. Sorry I was a little bit late this morning, but thank you very much.